everyone, and welcome to the Patient Pulse. In today's episode, we're going to be talking about getting your cholesterol to goal, the growing list of therapies. This talk will cover what LDL cholesterol is, why it's important to control, and its link to thrombosis. We are pleased to welcome Dr. Nicholas Marston, who is an associate physician in the Division of Cardiovascular Medicine at Brigham and Women's Hospital and an assistant professor of medicine at Harvard Medical School. His research interests include novel cholesterol-lowering therapies and the genetics of cardiovascular disease. Dr. Marston currently sees patients in the Cardiovascular Genetics Center and Preventive Cardiology Clinic at Brigham and Women's Hospital. So welcome, Nick. We're very pleased to have you talk about cholesterol today.
Thanks so much for the introduction. And again, my name is Nick Marston, colleague of Dr. Piazza's, and my talk today is titled Getting Your Cholesterol to Goal, the Growing List of Therapies. And so the overview of my talk is listed here. And so I want to cover first and foremost, what is LDL cholesterol and what is your LDL cholesterol goal? That's something I want everyone to take away from this. And second is, how can you achieve your LDL cholesterol goal? What therapies are available? And third is, are there any other lipid measures that you should be thinking about and wanting to address beyond LDL? And so we'll cover that as well. First, in thinking about LDL cholesterol goal, it really does vary based on the clinical history and risk of each patient. And so I want to go into that in a bit more detail. When we talk about LDL cholesterol, we're talking about what you may have heard of as bad cholesterol. This is cholesterol that can tend to get into the arteries of the walls, causing plaque and blockages that lead to heart attacks and the need for stents or bypass surgery. LDL continues to increase as we age, and so it's really important to keep an eye on your cholesterol and make sure that you keep it low and at your goal. This diagram on the right is from the Cleveland Clinic and shows that levels of LDL 160 and higher are actually in the dangerous range. Those in the 100 to 159 range are considered at-risk levels. Even though some of those levels are considered normal, they're still at risk. But really what we aim for in heart healthy is to be under 100 milligrams per deciliter for the LDL. And we'll get into some more specifics depending on the clinical scenario. One of the big distinctions in what your LDL goal is whether or not you're primary versus secondary prevention. And when we talk about primary versus secondary, we're talking about, have you already had an event, specifically an arterial disease event? So for the purposes of my talk, at least, secondary prevention refers to those who have had a heart attack, stroke, or stents, not a VTE, not a venous clot, such as a pulmonary embolism. Those patients would still be considered primary prevention if they have not had any heart attack or stroke. So that's primary prevention. Secondary, again, is those who have had events, ischemic heart disease, heart attack, bypass surgery, stenting, cerebral vascular disease, such as stroke, TIA, or carotid surgery, or peripheral artery disease, lower extremity bypass, stenting, or amputation. So hopefully everybody in the audience can kind of identify if they're in the primary prevention group, which maybe you've only had a blood clot in the veins, versus secondary prevention. And we can talk about what the LDL goals are from there. Within the secondary prevention group, again, those with prior heart attack or stroke, they really should all be on statin to lower LDL cholesterol. And the LDL cholesterol goal in this population is less than 70 milligrams per deciliter in the US. In Europe, it's actually even lower, less than 55 milligrams per deciliter. And so it's possible that the US will lower this goal in the future, and I hope that is the case. Patients with prior VTE, but without prior heart attack or stroke or PAD, again, are considered primary prevention. So we think about those patients a little bit differently. And there are three key patient groups within primary prevention who we want to lower LDL cholesterol with statin. And those are patients with very high LDL cholesterol. So those 190 or higher, we want to get their LDL down. Individuals with diabetes is another important group. And finally, those with elevated risk for ASCVD, and your physician can help walk you through what your risk may be. So to kind of summarize the LDL goals by group, I've made this table here. Again, secondary prevention, we really want you to be below 70 or lower. It's really the lower, the better. And then for primary prevention, It depends on which group you fall into. And typically we're looking at somewhere in the range of 30 to 50% reduction from baseline, or even greater than 50% reduction for those who are higher risk or have very high LDLs. And in the next section, I'll talk about how we can achieve those goals. So there's actually really 6 medicines, 5 classes that I want to talk about today. 2 of them are what I call the classics. So statins, of course, I've already brought up multiple times here, as well as Acetamide. These have been around for a while. And then I have 3 therapies or classes of drugs that are newer to the scene that I want to make you all aware of. So statins, I think we're all well aware of, and probably many of you are on these. There's a long list of statins, as you can see here, but there's really 2 that stand out to us as cardiologists as being the best because they're high intensity and they can lower LDL by more than 50%. And so that's atorvastatin, 80 milligrams or 40 milligrams, or rosuvastatin, 20 milligrams or 40 milligrams. So I'll typically use one of these 2 when I'm starting a patient on a statin. There are many other statins that can be used, but they're more moderate in their intensity and will only lower LDL cholesterol by 30 to 50%. In many cases, that may be good enough, but my take is if you're going to start a statin, you might as well get as much LDL lowering out of it as you can. Some statin pearls. This is a once daily pill, very safe and well tolerated, effectively lowers LDL, and most importantly, significantly reduces the risk of heart attack, stroke, cardiovascular death, and venous thromboembolism, such as pulmonary embolism. Next is Acetamide, and this is the second-line cholesterol medicine that we reach for after statin. It's also a once daily pill that can be added to statin. It also can be used in patients who are intolerant to statin therapy. The way it works is it actually prevents the cholesterol that you eat from being absorbed in the gut. And this drug is very safe and well tolerated. However, the effect on LDL is more moderate with only an 18% reduction. That said, it does significantly reduce cardiovascular events. And so this is a drug that's recommended for many patients in the guidelines if they're not at goal. So now let's turn to some of the drugs that are new to the scene. PCSK9 inhibitors are a class of drugs that can be tackled a couple of different ways. On the left are the monoclonal antibodies, which have been out for about 7 years now, approved for 7 years. And on the right is a newer drug, an siRNA called inclisiran that was improved just earlier this year. They're very similar in their mechanism of action, but the differences are that the monoclonal antibodies are every 2-week subcutaneous injections. These can be done at home. We have clinical trial data for up to 8 years, and these are very, very safe and well tolerated over that long follow-up. They lower LDL significantly by 60% on par with high-intensity statins. And they also have been shown to reduce the risk of heart attack, stroke, and again, venous blood clots such as PE. The siRNA, being that it's newer, we don't yet have the long-term data for it, but so far it appears safe and well tolerated, lowers LDL to a similar range of about 60%, and the outcomes trials are ongoing. Benpoic acid is another drug that was approved recently in 2020 by the FDA. Therefore, it's not yet in the cholesterol guidelines, but we may be seeing more of this in the future. It's another once daily oral pill that acts in the same pathway as statins, but does not have the muscle side effects. However, there is an increased risk of gout for those who have a history of it. It may be a drug to avoid. And the reduction in LDL is modest, 17%, so more similar to Acetamide. However, there's a combination pill with Acetamide that lowers the LDL by about 40%. So that can make it more attractive for patients trying to reach goal. The cardiovascular outcomes for Benpoic acid are ongoing as well, and we'll hopefully have results soon. And finally, the last drug I want to discuss is evinacumab. This drug was approved last year for homozygous familial hypercholesterolemia, or FH. It's a very rare disorder with super high LDL cholesterols around 500 milligrams per deciliter, and it's only seen in 1 or 2 per million. This drug targets ANGPTL3. It's a monoclonal antibody, and it's given every 4 weeks under the skin. It does significantly reduce LDL by about 50%, but unfortunately, it was only approved for homozygous FH patients. And so it's not something that we're currently able to use in a broader population, but there are other drugs targeting this same protein that hopefully will be available for LDL reduction. So I just summarized everything I told you here in a table just so that you have it. I'll move on, but this can be something you can go back to as a reference. But for my final couple of slides, I just want to talk about two other lipid measures that should be considered beyond LDL. And the first is triglycerides, and the second is lipoprotein A. So in terms of triglycerides, this is a separate measure that's on your lipid panel. I'm sure you've all seen it there before. The normal range is 35 to 150, and higher levels are associated with cardiovascular risk and pancreatitis. Statins are actually still the first line for moderate triglyceride elevation because they not only lower LDL, but they lower triglycerides by about 30%. If triglycerides are still high after statin, then we can turn to fibrates or omega-3 fatty acids to bring down those triglycerides even further. Whether lowering triglycerides reduces the risk of heart attack and stroke does remain controversial, so we don't focus on triglycerides quite as much as LDL, but it definitely is becoming a hot area with a lot of new therapies coming down the pipeline. And lastly, lipoprotein A is also a very hot topic. LPA carries risk of heart attack that is not captured by LDL cholesterol. This is a genetically mediated lipid particle that about 20% of the population have high levels of. The levels are stable throughout the lifetime, so you just need to check it once. It's not included in a standard lipid panel for that reason, but it is recommended to check once in adulthood. And while we don't currently have drugs that can lower Lp(a) significantly, there are new drugs that are in phase 3 trials and can lower Lp(a) by about 90%. And so we'll hopefully have dedicated drugs approved in the next 4 or 5 years. So I'll finish with this, a few take-home points. First, know your LDL cholesterol level and goal. The lower, the better. Second, most patients will be able to reach their LDL target with generic high-dose statin with or without acetamide. So that's very good news. Third, with plenty of new therapies available, every patient should now be able to achieve their LDL-C goal. Hopefully, with this information, you'll be armed to identify any risk from cholesterol that you may have, address it with your physicians. Thank you very much.
Thank you so much, Dr. Marston, for that wonderful overview. I think this will be very eye-opening for many of our patients. And thank you all for listening, and we will join you next month for another episode of Patient Pulse. Thank you.